There is a very clear bidirectional relationship where worse pain disrupts sleep and worse sleep leads to more pain. I think what's interesting is more recent research suggests that sleep might have a disproportionate impact on pain than the reverse. So for example, if you have sleep problems at time 1 but no pain problems, you are 1.5 to 3 times more likely to have pain problems at time 2. Whereas if you have pain problems at time 1 but no sleep problems, there's not the same increased risk for sleep problems at time 2.
And we became interested in studying the relationship between sleep and pain because Dr. Barwick, who's a sleep psychologist, many of her patients, about 50% that have insomnia, also have pain. And within the chronic pain population, research says about 88% of patients have chronic insomnia. I would say clinically it seems like it's even higher because it's rare to see a patient that has chronic pain that doesn't also experience disruptions in sleep.
It's actually one of the things that sparked our collaboration because so many patients I had walking the door were reporting chronic pain conditions, and Heather was having even more of that problem with folks who have chronic pain. So that's the reason we got together and began to develop this protocol to try to treat both problems together. Well, sleep studies are only necessary for something like sleep apnea or periodic limb movements, not necessarily for insomnia. So as Heather was saying, almost everyone who walks through her door is going to have some sort of insomnia, some sort of disrupted sleep. That might or might not include sleep apnea or other sleep disorders. But insomnia, you don't need a sleep study to diagnose. If we do think there's risk for sleep apnea, we'll certainly refer someone to a sleep study.
So cognitive behavioral therapy is an empirically validated treatment for both chronic pain and insomnia. I think the nice thing about CBT for both pain and insomnia is there's a lot of overlap in the techniques. They both focus on an educational component, whether it's about proper sleep or harm, pain does not equal damage, so there's like an educational component, but then there's also goal setting, pleasant activity setting, and probably most importantly, checking cognitions, thoughts about sleep, thoughts about pain that can perpetuate the unhelpful cycles that are associated with both.
And I think the thing that appeals, obviously we're psychologists, so of course we're going to want to use cognitive behavioral techniques. These are among the most well-validated and widely used in medical settings, especially for insomnia and certainly for chronic pain as well. I think what appeals to us most about this, though, is when you treat any sort of chronic condition, you need to approach it from a biopsychosocial perspective, which means you need to address not just the biological aspects, which the medical establishment can do, but you also need to address the psychosocial aspects. And something like CBT is perfect. It's a perfect vehicle for doing that. I would say when it comes to treating insomnia alone, it is very rare if someone actually does the recommended treatment for them not to get improved sleep. It's very rare. Almost invariably, if someone uses the strategies that we teach, their sleep will improve. And if they don't, their sleep will not get better. I've seen probably 2 people for whom that was not the case. I think it's more complicated when it comes to chronic pain. Insomnia you can actually quote unquote quote cure or resolve. Chronic pain you cannot. And the gains, I think, are slower. It's one of the issues we've been wrestling with as we've developed our protocol, because the rapid improvement you can see with insomnia alone does not occur at the same pace or in the same way with folks who have chronic pain.
Yeah, and with chronic pain, as Dr. Barg was mentioning, with insomnia, it's about cure. With chronic pain, this is a long-term management strategy that we're focusing on. So I'm not focusing on pain per se. I'm focusing on psychosocial factors that contribute to the amplification of pain at the level of the brain. So for example, catastrophic thinking. I'm focusing on the impact that the fear avoidance cycle can have on one's function. So unlike insomnia, where we can say, if you do this, it'll be cured, with chronic pain it's different. It's more about living the highest quality of life possible, improving your function, getting them involved in activities that are meaningful to them with the pain that they have. So it's not just about pain intensity, it's about levels of disability, mood symptoms, and unhelpful or inaccurate thoughts around pain.
there's a wide variability in typical durations. So for CBT for insomnia, the standard protocol used to be 8 sessions. We do 4. For a chronic pain protocol,
It's 8 sessions. Usually, if you're going to do group, it would be 2 hours a week for 8 weeks. But again, if you look at the research, there tends to be variability around that. But CBT is a short-term therapy.
short-term, I would say, and
Short-term-ish.
one of the aspects of CBT that makes it so appealing for any medical setting is its time-limited nature. Having said that, it used to be, CBT for depression or anxiety used to be probably a 12 to 16-week protocol. That has been increasingly downsized for factors that may or may not relate to the efficacy or effectiveness of treatment and relate more to changes in our healthcare environment. So I think it's unclear. There's certainly research to support a 4-session protocol for insomnia and an 8-session protocol for chronic pain, but I don't know if enough research has been done to identify the optimal number of treatments, and that may be an impossible question to answer.
Yes. So when you think about what contributes to one's stress, it's not the situation per se, it's their cognitive interpretation of what is happening in the situation. So when you look at identifying one's thoughts, are they accurate, are they helpful, that's the cognitive restructuring or the cognitive reframing component of CBT. So there's always a stress management component. And then any type of cognitive behavioral therapy protocol is going to have some self-regulation, whether we call it mindfulness meditation or guided imagery or progressive muscle relaxation, but something that pumps the brakes on the nervous system to help people feel more relaxed.
Yeah, the stress management really focuses on changing unhelpful, inaccurate, catastrophic beliefs about chronic pain or wakefulness at night. And if people can change their thinking about that, can get a better understanding of what that means, get a better understanding of the realistic consequences rather than the quote-unquote catastrophic consequences, their stress will come down around these 2 conditions. If people do what we recommend, their sleep will improve. Because we do see that over and over and over again. And so as a result, I've gotten quite firm about giving people the recommendations. And very clear if they don't believe, if they're unable to do them, then sort of helping them understand whether or not this is the right time. I do think it's a different issue with chronic pain. I don't think I work as well with a chronic pain population as my colleague does because I have a lot less experience with it. So it's been really nice to sort of learn from her how to work more effectively with this population. But I think it is different.
It's all about defining success. Mm-hmm. So if someone comes in and says, well, is this going to help my pain? I'm like, well, it's going to help your mood and your function and your ability to address different issues in your life that are in relationship to your pain. It's not a guarantee that pain levels will be lower, but we do see that. I think as people are less concerned about their pain, engaged in activities that bring meaning to their life and sleeping better and going out and doing things, they do report lower levels of pain, but my focus is not on pain per se. It's about the impact, it's on function and the impact that the pain is having on their overall quality of life.